Good afternoon, everybody. It's amazing. It's amazing how quiet it got right before 1:15. It's like everybody's like on time and has an internal clock. So, welcome to the Societal Determinants of Health, New Models of Partnership in Housing session. I hope you're all enjoying your afternoon and your day here as much as I am. My name is Rosamaria Martinez. I'm the Vice President of Community Health Initiatives at 16th Street Community Health Centers in Milwaukee, and I will be your moderator today. Before we get started, I just want to briefly describe what you can expect in our session today. We're going to have a format of about 5 minutes of opening perspectives from each of the panelists and about 45 minutes of moderated questions, and then we turn it over and we lead it to you to ask questions that you may have so that for the panelists. Our goals are to, as they mentioned today at our lunchtime, to pull together multiple perspectives, policymakers, researchers, clinicians, practitioners, community leaders, to have a collaborative discussion. And discussions are to be embedded in research, data, evidence, and experience to foster innovative and solutions and identify opportunities for collaboration. So that is our goal. So on my way here yesterday, I was listening to a podcast, and although it was a very different context, one of the quotes stood out to me, and the quote was, "We need to struggle with this to help figure out what's next." And I feel like that embodies what we want to do today, is to have a discussion to figure out what some of the next steps could be. So with that, so across the healthcare system, there's a growing awareness of education, safety, environment, employment, and other social circumstances significantly affect a person's health status. Our focus with this panel will be on one such determinant, housing. Today, with this fantastic group of women, we are going to talk through the intersection of population health and the impact of innovative programs to address housing and homelessness. It's clear being proactive is key. And unless we are proactive in asking our patients about various social determinants and connecting with people at a more personal level to get a deeper understanding of housing needs, we won't know what the issues are, what issues they are facing until it manifests itself in a greater social or economic issue, perpetuating the same system. In essence, their stories matter. Like the panelists and others in this room, we at 16th Street see firsthand the impact housing has on the health of our people. We see it in our clinic walls, we see it in our home visits, we see it in our work that we do in the community, that housing is a determinant that is much broader than being homelessness. It is much more than a binary answer of yes, no, I am homeless or I'm not. So plainly put, housing is critical to health, and as a healthcare provider, we know this needs to be reflected in our care delivery system. Achieving the best health outcomes for our patients and community depends on prioritizing these issues across the board and interweaving the act of addressing the social determinants, addressing these issues within our primary care clinic flows. So clinical care and addressing these social determinants cannot be in silos. They have to be interconnected. And that's what we've done at 16th Street by screening our patients before they see the doctor, so that we don't have to wait for the doctor for the patient to tell the doctor what the issues may be, because they might have not connected the two pieces. So we know that we are not the only ones tackling these issues, for sure. A lot is being done, and I'm sure by many people in this room, to fill the gaps and make strides from all angles, because the issue is multifaceted and spans all disciplines. So with that, as housing is critical to health, but the path to making an impact on a scalable level, it's not always clear. So that's why I'm really looking forward to speaking and hearing from these wonderful experts to shed some light on how we can make this better so that our community can live their healthiest life. So with that, I'm going to introduce you to our wonderful panel. There's more detailed on their bios in your program, so I will just kind of give a brief introduction. We have Marah Curtis. She's a Vilas Distinguished Achievement Professor at UW-Madison School of Social Work. Her research focuses on differences in housing conditions, benefit policies, and contextual factors that affect the health and well-being of families. We have Nina, Gregerson?
Yeah.
Okay. Yes. Okay. Right, so, Health Education Coordinator, Public Health Madison and Dane County. She's a health education coordinator for the Public Health Madison and Dane County for 7 years. And she has extensive knowledge and skills in systems, policy, environmental change strategies, community engagement, and health equity. And we have Christina Orr. Christina is she's taking a position at the Milwaukee VA. She's been at the Milwaukee VA since 2006, and there she's had several roles, including acute care physical therapist, medical center ergonomist. Sorry, it's after lunch. And health system specialist and executive assistant to the deputy and assistant directors. She currently serves as the assistant medical center director. And last but definitely not least, Ellen Sexton. Ellen is a CEO at the UnitedHealthcare Community Plan of Wisconsin and is accountable for directing the clinical member services and operations of the health plan that serves 190,000 Medicaid members. Her focus is driving new solutions, tackling social determinants of health, and high community engagement are major focus areas of Ellen's team to better serve Wisconsin's Medicaid population. So with that, I'm going to ask each of the panelists to take a few minutes and for their opening statements. And we'll start with you, Marah.
Okay, thank you. So how are you all? You doing okay? So I'm excited to do this today because I'm ever hopeful that the things that I think about every day and the papers that I read and think about every day about some aspect of housing and some outcome can be used to think carefully about how you might design and deliver better quality housing, which then would be significantly associated with health outcomes. So that link between kind of the empirical base around health and housing and then what you actually do in communities is not always obvious. And what might work in place A might not work in place B in terms of your stock and in terms of the players. However, I would say that one thing that works across all housing markets is sufficient income to secure a suitable unit. The bottom of the market is tight everywhere, but a tight market suggests different solutions than a market where people have difficulty affording, but it's because of low incomes. So even within this state, you have quite a bit of variation across the cost of housing, things like your vacancy rates, which then implies that you have to think about your solutions differentially. So what I was excited about with this panel is that housing is collectively created, maintained, and managed. So there isn't the potential to serve housing and health well without working in groups of people. It's just not possible. Otherwise, I would just keep writing papers, and that would be awesome. But it doesn't cause it to be so. So I guess that's what I would say. I mean, I'll look forward to talking specifically about different pots of research, if that is helpful. Some of it's associative, it's not causal, but some stuff is causal, right? Which I think should help us think about perhaps some federal levels or federal levers around perhaps stabilization. You have to think about what you're doing in a local market. I'm particularly excited to think about some of these new experiments where large health providers or insurers are making a huge imprint in a particular area, not just on the patient population, but on the community level, right? Which is where the reproduction of health, one can argue, really lives. So I don't know. That's what I would say to start.
Thank you.
Yeah.
Nina?
Oh boy. All right. Can you hear me? Yeah? Great. Good afternoon. So I'm bringing kind of like the local health department perspective because this is such a complex issue. But I think we can play a huge role in this area. So housing is a public health issue. Let me repeat. Housing is a public health issue, and we must treat it as so. It's a crucial social determinant of health that impacts both mental and physical health. The way I think about housing is in 3 different arenas. It's the affordability piece, it's the quality piece, and it's the stability piece. And you need access to all 3 of those to have health and well-being for not only individuals, but families and communities. As health departments across the country are moving towards a public health 3.0 model, we must engage in other sectors and community partners in order to generate collective impact. But housing is a complex issue, right? And there's many evidence-based strategies to address it, including building new affordable units. But I want to emphasize that we can't build our way out of this problem. We must look at what other communities are doing and collaborate with community partners in a holistic way to address the housing issue and improve housing stability for all. I'm really lucky to work for a health department that is starting to do this work through our community health assessment that we just wrapped up late last year. Housing was our #1 priority, and that was truly from the community telling us we need to start working on housing and improve housing for everyone in our community. So I'm really excited to be here and to learn from all of these lovely women up here and hopefully give you some insights on what's happening here locally.
Great,
Hi.
thank you.
Hi, everyone. I'm Christina Orr, and I work at the VA, the Milwaukee VA, or as we call it, the Clement J. Zablocki VA in Milwaukee. So I come here with a unique perspective talking about the veterans and how do we improve the homelessness situation that way. I do want to just tell you our mission statement, which I think speaks to where we go. To care for those who shall have borne the battle and for their families and survivors. And so when we think about our veterans and every day when we go to work, this is what we look at. We see this on a lot of the papers we put out and emails and so forth. But where I'm going with this with homelessness is that, unfortunately, it's an epidemic that's growing. And how do we help this? We can't be siloed. We need to come together and collaborate, and I think that's the way that we're going to get through this. So even though I'm bringing forward the veterans' perspective, I want to make sure that we're here. This is really fun for me because we get to talk about and unite and hear everyone else's perspective. But some of the unique things that our veterans encounter when they come back from the theater, as we call it, the warfare area or active duty, is that a lot of them, and not all of them, but they come with PTSD, mental health issues, substance abuse. Some of them come back to families who may have moved on, and you don't necessarily hear about that a lot, but it's difficult to reintegrate into society. And so when we look at them and we say, why are they homeless? There are a lot of factors that cause this. And, I often say, what comes first? They say the chicken or the egg, right? But what's more important? Do you need housing or a job? It kind of goes together because if you don't have a job, you can't often get housing. And so just trying to look at the whole picture and how we go from there and helping our veterans get this foundation, because without it, you have more ED visits, you have more people tend to lack or to delay health care, and so something that could be minor tends to be more, becomes worse later on. And so how do we help this situation? And I guess that's why I'm here, is to have that conversation today. So, yeah.
Thank you. Ellen?
Last but not least, right?
Last but not least.
Hi, I'm Ellen, and as she said, I, alongside my team, we serve 190,000 beneficiaries across the state. And what that really allows us to see firsthand how housing impacts, and to Marah's point, right, every county is unique in its situation, and some of the different things that we deal with in Milwaukee is really different than what you deal with in rural areas of the state, but they all call for solutions. And I think when I think about it, our case managers see it firsthand, right? And so if you think about a diabetic going in and out of a shelter, they can't possibly keep their insulin at the right temperature. They can't possibly be eating the right food at the right time. And so it really starts to make sense when you talk about housing is healthcare. And the other point to it is that the housing first concept, so the chicken and egg maybe as you were referring it to. So if you start with housing first, that's how you make sure that you get people onto the right healthcare plan and journey, starting there, whether they have substance abuse or whether they have a heart condition. You have to have housing first to get that under control. And so for me, what I'm excited about first is to show you a model that we've implemented in Milwaukee around paying for housing. She's shaking her head because 2 years ago, Marah and I were on a panel and we hadn't launched it yet. It was just a vision, and now we've launched it since August of 2018. And what's great about it is we've got awesome data around lower ER, lower inpatient, and then even better stories about the people and how they're connecting with their family and getting jobs and things like that. But why I'm also really excited is, right, we did this sort of prior to policy. So what I'm hoping is you're all listening to, okay, how do we put this into policy so that we can take sort of a small program that we've implemented and make it even bigger?
Thank you. So Marah, let's start off with you. What does the research and evidence tell us about the health impacts of access to safe, stable, and affordable housing?
Okay, so I guess I'll say a couple things. First off, the research base around some aspect of housing defined in various ways, and health is rather large. But the way I find it easiest to think about it is to think about, like you said, quality, stability, and affordability, and there's slightly different pots of literature. So let's just first think about quality. There's evidence within country and across country that the quality of your housing, the presence of mold and bed bugs and environmental bads are negatively associated with health. Community health and individual level family health, both domestically, and there are quite a few studies in parts of Australia, right? So that's pretty solid. There's a whole research base, much of it strong. So that's not something people really push back against. You're not going to have anybody arguing the other side with any evidence that, you know, lead isn't bad for you, and dust mites and the like, right? So that's a strong pot of evidence, both domestically and internationally. Stability is a little trickier, right? How people think about that. So a lot of the research there kind of looks at measures of individual income. How much of your income are you spending on housing? And if it's more than 30%, you're considered housing burden. Some people don't like that way of measuring it and that way of thinking about it. You have a bit of a causal ordering problem because some folks could argue people are choosing to be rent burdened, and so they look like they're rent burdened on paper, but they're choosing it because they want higher cost housing, because that higher cost housing is in a better school district, which may deliver better outcomes for their kids. So I say all that to say that it's somewhat messy in terms of the research, but overall, nobody really argues that paying in excess of 40% of your income for housing is reduces your ability to do other basic things that you need for your money. It's not a causal story, it's an associative story. Okay. Now, one other thing I would say about the few things that are kind of causal in these bodies of research, or some of the, so you have the kind of the moving to opportunity a study, and then we have some reanalysis of that data where you're taking folks who receive housing vouchers, which are really quite scarce, and some folks needed to use their vouchers in places with lower poverty. This is more thinking about how neighborhood opportunity affects outcomes. This was longitudinal and over time in a good research design. In the early MTO studies, they found health effects. They weren't looking for those. They didn't necessarily affect them, right? This is about 15 years ago. There's been some reanalysis of some of the MTO data and some new studies coming out. Chetty, do you guys know Chetty's work? Mm-hmm. Okay, right. And so this is the idea that if you use vouchers or subsidies to access higher opportunity neighborhoods, there's a whole bunch of measurement stuff, like what's a high opportunity neighborhood and how do you measure that? He's finding positive earnings outcomes and positive health outcomes, right? And so that's a causal body of work. But then of course you say to yourself, well, we can't move everybody everywhere, right? We can't just voucherize everybody and say, hey, get going to another place with higher opportunity. So I guess I say that there are a whole host of different solutions that the literature suggests, which could have some part of it that's about vouchers. You take your voucher and you access a higher quality neighborhood, right? But that can't be the whole story, right? So So when I think about the different research, and I think about the research that is more causal, I think it suggests an array of potential solutions that might work. Here's the last thing I'm going to say, and this is around the body of research that's specifically about homelessness as an outcome. There are 30 years worth of studies on this. A lot of the early work really just argues about, is it individual factors? Is it macro factors? And basically, I could summarize the whole kind of homelessness outcome literature to say that there is a basic agreement that it's yes and, however. There aren't too many causal studies, but there's a couple. And what those studies find is if you take individuals who are exactly alike in all dimensions, but you put them in different housing markets, they have differential poorer health outcomes in tighter markets, all else equal. So that's something to pay attention to. Is this understandable how I'm talking here? Mm-hmm. Okay. There it is. I think that's a good summary. You can get into the weeds if you want to. But.
Thank you. Nina, I'll turn to you. What are some innovative community-based model strategies that are successfully addressing access to safe, stable, and affordable housing?
There's a lot.
All right, list them out.
Yeah, no, one that I really love, and I know that there's some preemption and things that we can't do locally, but I love the idea of proactive rental inspections. Does everyone, probably not everyone, but proactive rental inspections takes the burden off of residents having to complain when their housing is not up to par or not up to standard. Something that we experience here in Madison is people, rightfully so, being very fearful to complain about substandard housing conditions, to the point where they fear retaliation, they fear eviction, they fear non-renewal because they're on a month-to-month lease. Yeah. So one way, and we know that complaint-based processes are inherently inequitable. We know that for a variety of different processes. And one way that we could take the burden off of these residents who are experiencing these awful living conditions is to implement proactive rental inspections. Now, there's some caveats. The best way to do that is to license or permit your rental units, which we're preempted on. However, we could do proactive rental inspections, random rental inspections locally, but we don't really have anything to recover the costs for those, which is a problem because it's not sustainable that way. One city that's doing this very well is Kansas City. They require a permit for all rental units, and then they use those rental unit fees to fund 12 inspectors who go around and inspect every unit every 4 years. So they've figured it out. They do it pretty well, and they're already showing much better outcomes after about a year and a half of being implemented.
Wow.
So that's, I think, one thing that would really improve the health and well-being of our residents here in Madison.
Can I just ask, how is that, can you talk a little bit about how is that overseen in Kansas City? How do they?
Yeah, great question. Actually, their health department does it. Yeah. And they charge, I have it here, $20 per unit every year. And then they charge a fee, a $150 fee, if they require to go back and re-inspect because there is a violation. Mm-hmm. So, but yeah, those 12 people who are funded by these permit fees are housed within the health department.
Interesting. Thank you. Ellen, do you want to add to that question?
I'd love to. But I like that. That's really cool. I hadn't thought about it like that. So what our housing program is it's called My Connections. And what we do is we look at a subset of our membership that we think has really high impactable medical costs. And you can think of some of these people, they're anywhere from $50,000 to $100,000 a year, right? High ER visits. We had one individual, she was going to the ER 225 times a year, right? She's not going to the ER necessarily for a health condition. There's a lot of other things underlying that. So we work to identify those members Some of it's through, yes, impactable medical costs, but some of it's our case managers know. They know who housing is really impacting them. Could be a pregnant mom that's supposed to be at bed rest and she doesn't have. And so when I say housing, it's sort of a broader definition, but she could not have access to food and be running to the food pantry, and because she doesn't have a fridge and a stove because they've just moved into this apartment and they don't have those appliances. So our case managers not only are empowered to do the health needs assessment, but to actually act on that health needs assessment. So we look at members that have a high impactable cost, and then we work with Milwaukee County Housing Division. We have an arrangement with them where right now it's small, but around 10 to 15 individuals at any given time. So the housing part of it is important, right? It's scattered housing. And when I say that, it's not just one complex that we've set aside. And that's really important because all of these people are individuals. They have different tastes. They have different lifestyle. And so they help us to have a scattered housing approach. We get them moved into the housing first, and then we work on a case management plan to get them on the road to their right journey. And so I'll just give you, I said before, we've been doing it since August of 2018. But just to give you some stats around 12 individuals that have gone through the program. The 12 months before, they had 81 inpatient visits, and afterwards they had 17. Inpatients around 10 grand. I'll let you do some quick math. We can look at that as an overall healthcare system savings. ER visits, these 12 had 285, afterwards 61. So you think about that as far as just these individuals and the savings that you're producing on them, but then think about the entire system, right? This allows doctors to focus on what they should be focusing on, the health of these individuals, and getting these individuals on the right path to their own health. And I also tell you, part of our program is to graduate them. So this isn't housing forever or housing for all. This is to help them on their pathway to better health. And so we've had 6 individuals graduate. We had one, I think it was 2 weeks ago now. She has a heart condition. She was a former heroin addict. She now has a job, so that's why she's graduating, $17 an hour, and won't even be a Medicaid beneficiary. So these are sort of the life-changing as well as health outcome-changing that housing can actually do. And so when we talk about graduating, part of the criteria is first that they're following their health care plan. Second is that they have a Section 8 housing voucher, and or if they don't have that, a pathway to income, whether it be a job or SSI. So again, it's the whole entire person and not just like an episodic case, as well as the fact I would tell you that to get these individuals to this point, there's some really intensive wraparound services, right? We have an individual that's going almost every day to visit these people, and that's what it takes. But it also means that, right, that individual isn't going to the ER and using up resources there. So it's a different way to think about it. I didn't really wait for the system to ask us to do it. I mean, our case managers are seeing it every day, and a solution to it seemed somewhat obvious to us, but maybe a little bit different than how you would think about an HMO approaching the problem.
You talked about the person going to the ER less often. And thinking of the stories that you're talking about, and a significant barrier to addressing housing needs involves the stigma around healthcare. Around homelessness and housing. And you talked a little bit about the wraparound resources. So what models are available to successfully work through the stigma with individuals and families?
I don't know if I call it a model, but I do think about it, first off, from the human aspect, right? I can't imagine as a great nation that we can't be working together and we can't be figuring out ways around housing when we know how it not only impacts that individual, but our entire society. So I start there. And then the second part I think about is just the stigma notion that you talked about. And so if you think about the Medicaid population, 60 to 70% of them do work, right? It's just back to Marah's point, affordable housing isn't available. And so you get to a really narrow band, and even like Drew Altman was talking about, one shock to them and their income, whether it be some sort of healthcare crisis where they can't work, whether it be something within sort of their overall income stream that impacts them, and they're suddenly homeless, and they don't have, a lot of people don't have the same infrastructure that other people. So I just think it takes a little bit of us realizing that our entire system could be better if we figure out how to actually think about policy, how to think about braided funding, and how to think about sort of the connections that if you make for these people can actually improve outcomes and improve the overall funding source too.
Connections is key, right? Because it is so multifaceted and really does span across so many different disciplines. Christina, can you talk about what partnerships are central to improving the housing crisis experienced by so many in our state?
Yeah, I would say that there are quite a few. I mean, we can't do it all alone, as I said earlier, but I would like to share, before I go into detail on those, just about what we're doing at the VA. We're kind of going to use yours where you said last time you were talking about something you were about to do, and now you've done it. Well, I'm going to talk about something we're about to do. So
we'll talk to you again in about 2 years and see how it goes.
Well, maybe less than that. But in 2021, the VA is going to be opening up our soldiers' home. So we're a historical landmark. And so we have this huge building that used to be the old soldiers' home, our building 2, and we're going to be opening up 101 homes for homeless veterans. And that includes for veterans, like individuals, as well as married veterans and families. And so this is going to add a really unique dynamic to our campus, which is over 320 some acres. But we'll now have, at that time, we will even have kids on our campus living. And what this does is we'll have, in the really big building, we'll have 80 units, and we'll have 70 vouchers that'll be available to our veterans that they'll receive some type of programming, whether it be like through our HUD BASH program that we have. But this is all to help them become stable financially, medically, including addressing all the issues I said before, PTSD, mental health, all of that. But this housing is one of those that starts off and transitions into a permanent house for them. It just has to be the right size. So if a family of 5 came and those kids grow up, those parents will not live in that same unit the whole time, but they would downsize if they needed that housing. There are certain criteria that they'll definitely have to follow, but we're looking at this as a positive impact, especially for the Milwaukee area and the state. So there's some unique challenges and things that we necessarily didn't think about, like looking at the Postal Service and where will they deliver their mail to, and all of those type of things as we go forward with this. But it's a big undertaking, and I think it's going to be a beautiful project when it's done. It's just getting there. But right now we're in the renovations part of the building, so that's a big one. So we're hoping, and that, when I talk about partnerships, we're not doing it alone. So yeah, it's on the VA campus, but it's through the state, it's through National VA Central Office. It's also through our community programs such as HUD, WIDA. The Alexander Company is a big one that's a private one who's helping renovate the old building. And as if I didn't mention before, we're on a historical landmark. I think I said that. And with that, there are only so many things you can change about the buildings, especially on the outside. So we definitely needed the help of that. And so we are really grateful for what this has done and brought forward the community. I mean, we have people all over the nation coming and meeting with us on a regular basis to make this successful. So again, there's just so many things you just can't do. This isn't a problem that's VA centric or specialized, or it's not just on the outside or in the public. It's everyone, and we have to work together in order to help that. I think when you look at homelessness, a lot of times people don't go out and advertise and say, hey, I'm homeless, right? So where do we find those people that are homeless, and how do we get them comfortable to tell us that there's a problem or that they need help? And so some of the areas in which we really need to partner with are like the schools, the public schools. A lot of times children are more vulnerable, and you tend to, if you observe them, and you're a good teacher, right? You're paying attention and you're like, something's just not right here. So how do you get that conversation going? Also, we keep talking about healthcare and these repeated visits, and how do you notice trends, and do they see the same provider on a regular basis, or do you see in their chart that they were just here last week? Or is it something that could have been taken care of earlier that was simple and they just didn't want to come in? So those, I think, working with local EDs, public schools, and just, and some of the private ones that are out there as well. I mean, there's some clinics, like some of the pro bono clinics, people come in and they don't necessarily want to tell you why they're there. I've worked in them, but they're there for a reason. So.
Thanks. Ellen, do you want to add to the partnerships question?
Partnerships are, they're vital to this, right? Because again, you're looking at something, the intersection of healthcare and housing and even social services, community-based organizations that don't always naturally work together. But what I'm finding is when they do work together, it is really a beautiful thing. And sometimes I watch our external partners actually understand the solution and the situation a lot better than even some of my internal partners. And so I think, Milwaukee County Housing Division is just really, for us, been a great partner. Right now they're looking at our model and even saying, well, we could do more if we put a dedicated resource. And I'm like, yes, exactly. So they're anticipating things and how to move the model along really quickly. 16th Street, I'm so appreciative for the work you do every day. And that is where, the partnership from that perspective and how we look at that is important. This isn't for anyone siloed part to say, hey, we can do it better. We can do it better if we work together. And you talked a little bit, how do you identify people and their needs? And a lot of the times, developing the trust with each of these individuals takes some time. And I think each different partner brings a different relationship to the table to build that trust. We work a lot with the paramedics, and people trust the paramedics and tell them a lot of things that they wouldn't even tell the doctors sometimes. And so that's part of it, and part of partnerships and how we'll actually also really move the ball on this is data sharing, and we talked a little bit about it, but making sure that across the system that every time that individual comes back into the system, that people actually know, well, they have a housing need, so that they don't start over that conversation and have to go through, I'll say it right, a really complicated and painful conversation a lot of times. Why make them go back through it if it's something we already know across the system? And then the other part of data is that, what is it? Practice, research, policy. That's where you can get all your research. So here's an individual, we put in housing, here's what happened to actually their medical costs, and this is what then makes for good policy. And so having all those connection points and knowing whether or not somebody, used a Section 8 or went to the food pantry just makes it a much more complete understanding. And also, you made the reference of, do they actually go to the same provider? No, they don't, right? So you have to have the full picture if you're going to treat somebody from a whole person perspective.
Great point. Thank you. Nina, did you want to add to the partnerships discussion? I know you've seen a lot of different models. I'm curious to see if you have.
Yeah. From a governmental standpoint, we have to break down the silos that we work in because there's so many agencies that are working on housing in some aspect, but we aren't collaborating. And that's starting to happen here locally, which I'm fortunate for. But I think we could do a better job. And I think part of that is that data sharing when it comes to problem properties, right? we should know where those properties exist and what issues are what we're seeing, and how can we better serve the residents that we work for. But in addition, I think echoing the same points, healthcare employers. So if you have bigger employers in your communities, they could play a huge role in this housing crisis. They could help invest in workforce housing. Neighborhood associations, property management companies, so they should also be at the table, along with tenants, right? We can't do this without them. Policymakers, because they're the ones that are making those policies or lack thereof. And then your community-based folks, so nurses, social workers, and other community-based organizations.
Thanks. You referenced a Public Health 3.0. Does that have anything to do with, I've heard that term a couple of times. Does that have anything to do with partnerships related, or
Yes.
something you want to talk about?
Yeah, so Public Health 3.0 is this model or this idea that we kind of serve in public health as the convener of all of these different sectors. And we can't move or improve these social determinants of health without engaging with those multiple different non-traditional public health sectors.
Thanks. And Marah, what changes could policymakers consider to address limitations, barriers, and otherwise improve public policy pertaining to housing?
I think it has to be reimagined. I think the problem has to be reimagined. So think about how we're thinking about this right now, right? We've been talking about folks who are in the VA system. We've been talking about folks who are in the Medicaid system. We've been talking about HUD-VASH vouchers. So we've been talking about one end in some of the most vulnerable folks. However, that's one proportion of the overall picture of housing, and that's one part, people far short of these experiences and not connected to a VA where you do get benefits. So the VA can screen, because if you come up positive, they can do something about it, right? So you're capturing people who are somewhat covered, and then we're talking about that. But then there's this whole other experience that folks are having far short of the most extreme usage of medical services or in the VA system, who have all kinds of housing stability, cycling in and out and in and out. One thing we know from the research is folks that have this kind of instability in their housing can dip into homelessness or out of it, right? And so I think part of it, because we're working in these service sectors, we think about one end very much. But it's part of a larger thing. Like, I got up in a house this morning, and I have neighbors that are super important to my well-being in my life, and I'm part of that same housing market. So it's this thing where I think we have to think broader about housing as an input to health across the income distribution. I think we pay a cost when we only think about what is happening on one extreme, and we don't think about how we subsidize it on the other end. Right? So when we think about the amount of money that we spend federally to subsidize home ownership, thank you so much. I'll get my check and it'll be awesome. No one asked me for anything. It's $58 billion in the last tax year. We spend about $38 billion at the lowest end of the market. So the way in which we subsidize renters and owners and where that flows is part of the larger policy relationship to how we provide housing and who we provide it to. So I just would offer that, because I think we have to reframe the whole thing. So when you reframe the whole thing and you think about how much we're subsidizing the home-owned market and how much we are doing vouchers, we think about it more broadly. So I would also offer this. When you think about housing, you think about it over time across the life cycle, and you think about being consistently, stably housed over time. So we learn a lot by looking at when those things are absent, but we could also learn by looking at when you have access to that over your life cycle, what does that do for you? And if you're talking about creating communities where you have access to these things, then you can reason yourself to something like you talked about the rental inspections. How is it okay that you have a housing stock that is hazardous quite clearly to health? That's a public goods issue. So I would argue for a larger reframing across the entire housing market about what we think is a health input, and not only focusing on some of our income condition programs, but how is it okay that our housing stock has environmental bads? There may be preemption, but you still have to state what the problem is. Okay. Sorry.
I love it.
But how do you feel about it?
I have no feelings. Very calm.
You talked about the rental market a little bit and how it's central to affordable housing. So what do we know about the experiences of low-income families in the rental market? And how should this influence our approaches to addressing homelessness? Marah?
Okay, the whole thing that I started out with about how the markets vary quite dramatically. So if you've been watching the local news, how many of you have seen these moms in Moms for Housing who have been doing these political actions, right? So that's one kind of housing problem in an incredibly expensive housing market. So we might imagine that you need different levers there than in some of the work that I do in Milwaukee, where the fair market rents for affordable housing are below the national average. There, it's an issue of low incomes and poor quality housing. So I say all of that to say they're all, the market issues vary dramatically. So what things you would reason to in a really tight market where, I just looked this up the other day, where, you know, a 2-bedroom is, you know, $2,500 a month or $3,000 a month is a different solution than it might be in Milwaukee. Now, so there are buckets of solutions depending on whether you have a tight market and depending on the quality of your house. So I'd go back to the quality, stability, affordability thing, and then folks who are working on the ground with what folks who are in the rental market are telling us are the challenges there. And then I would look to best practices for other similar geographies with similar vacancy rates, similar housing costs, and I think you could borrow. So the West Coast is incredibly expensive, and so but you have lower home ownership rates and higher renter rates. So you have a within-class renter cross-race coalition because there's no way to survive in those places without it. So can we learn from that? All right, if it works here, maybe that works in Madison, not Milwaukee. Okay, and so where the Kansas City seems like they have a quality problem. So what are they doing? What works there? So that's the kind of way I would. But I would first understand my market, understand the players on the ground, understand what people are telling us is bothersome to them. Sometimes when I've worked with community groups, in my head, I'm like, this is what you should do federally. But people say, yeah, that's fine, but I'm really catching it around this or I'm really catching it around that. So I think you have to be able to do both. You know, you can't just come in and tell people they should do this. But you have to keep the meta in mind at the same time, I think. So,
Thank you.
sorry.
And Ellen, you touched upon this a little bit, but how do you see housing and other social determinants of health impacting the members you serve?
I mean, clearly, right, all of them impact it along the line. So housing, right, is something we've been spending a lot of time, but transportation is just as much a one, right? So can they get to their medical appointment? And, you know, one of the things that I think we're slowly, hopefully making some policy change around is, right, being able to take your kids alongside on that transportation, right? So you're a mom, you have 2 kids right now, the transportation for it, you couldn't bring them along. Well, that makes it really difficult for you to get there. Transportation in rural areas, right? You know, some people to go see a lot of their specialists, it's 100 miles. So making sure that people have access to their appointments through transportation on the medical side, but then also if you think about the infrastructure even further, right? So we talked about if you don't have a job, how do you pay for your house? Then how do you get your health care? So just even thinking about jobs in general and transportation and the right infrastructure around that. Think about food insecurity. I talked about a diabetic, but just in general, right, our healthcare issues, obesity rate, diabetes is all about, right, healthy food. And so how we get healthy food to our members, to me, is really important. And it's not just enough to be able to go and eat food, it's got to be nutritious, and how we make that more available to people is really important. You know, I actually throw technology in there because the more and more that technology can start to actually increase gaps for people is going to be there. And a lot of times, right, our members may not have a house, they may not have a car, but they do have a phone. But then for some members, they don't. And so, like, how you actually make sure that they still can apply and understand things from eligibility requirements and what they need to make sure they've had. So it impacts entirely, and so there's the medical and there's the behavioral side of it. But for us, right, it's something that we look at every day, and I think our case managers are really empowered to act on it. But 80% of somebody's health happens outside the doctor's office, and it's for all these reasons.
And I would say, too, education. I can give it an example of here in Madison, there's a neighborhood on the west side, Park Edge, Park Ridge, for everyone who is familiar with Madison. Part of the neighborhood is covered by Madison School District. Another part of the neighborhood is covered by Middleton Cross Plains. A lot of families in that neighborhood are subject to slumlords, right, and non-renewals and evictions. And the impacts that has, or evictions and moving for families and for kids in particular, is incredible. So we hear stories of families having to move even just across the street and then have to re-enroll in a different school district. That has long-lasting impacts on that student's educational attainment, as well as future income, wealth, and health outcomes overall. So we have to consider that too in this problem, is the impacts that it has on our children and their education.
Thanks. Christina, did you want to add to that?
I was just going to say I could piggyback on both of you guys, but when you're talking about education, I was just going through my head is that I ran into a kid who was 8, and he had lived in 8 different places. And so when you asked him what was his address, he was like, I think I live, and just, at 8, you should know your address, right? Mm-hmm. Or you should at least know the town in which you live in. And he did not know that because he had lived 8 different places, and actually he was about to turn 8. That being said, you think about when people go to apply for a job, and I hate to, and I'm sorry if I'm offending anyone, but we live in a judgmental society, and I know it's no one in here, but but when we're looking to hire, we want the best of the best, right? But what would you do if you see that someone doesn't have a home address? Are you going to hire that person? I'm not saying that you should or you shouldn't. All I'm saying is that a lot of times people look to make sure people check the boxes. And how do we go and give people that chance? And that's a stigma. So whether they don't have a permanent address, and that's something that I know and I'm sure a lot of other people take for granted, that I have an address. I have a mailing address. So even though things are electronic, I have a place where I could get a check, or I could get, I have an email address. And sometimes people might have that, but they have no way to check it. So I think that in many ways, it's just challenging for people who are homeless to want to exude confidence, to be the person that they know that they can be with this stigma that's right behind them, and they're saying, I wonder if they can see through me. Can they tell that my clothes aren't ironed, or that they were balled up in a bag, but I came in for this job interview? So I think when we think about the silos and we think about, we want people to be successful, we also have to make sure that we as a whole are open to that, because there's a lot of talent that's out there that people just don't have the chance to do. And sometimes it's a matter of how do we help groom them. And I don't mean that in the fact that they don't already know, but sometimes there's some people who are just rough around the edges a little bit, and all they need is a chance, and then they may be able, they'll exceed your expectations or their own expectations, and how do we give them that chance? The other issue I was going to say is that also suicide rates are going up. And so with this stigma, how do you, that's something that's weighing them down. And we want to eliminate that. I know that's a big focus for VA, is that we're trying to reduce the number of suicides within our veterans. And if people don't have homes, maybe they have families, they have other responsibilities, how do we take that burden off of them or take that stigma? Because I don't think, I'm not saying that, we're all here for a reason, right? But the world isn't this big. We don't all have our arms open to hug somebody that we see coming off the street, right, who wants a chance. But how do we get there? How do we know to give someone a chance?
That's a good point. We had we work with one of the schools in Milwaukee, and one thing that came up in a support group that was in the high school, an opportunity for people to talk about some of the issues that they were going through, the kids. And when you talked about somebody living homelessness, and one of the kids that they called GQ because he was always dressed to the T, was homeless. And because of that, you just kind of mentioned, do they know that it's balled up to the T? I think he specifically found ways to try to look the part so that nobody ever guessed that was something he was going through. Marah, you've talked about the continuum, the housing in a continuum from stable to consistently housed to a living with a permanent shelter. How does that concept impact your approach to addressing this issue?
Nuance. It forces me to think about nuance. So, and why this matters is that particularly with the research, let's talk about the pot of research that calls the outcome homelessness, right? And then you write papers in this area and you publish and you go speak about this stuff. I've spoken about this stuff here and I've spoken about this stuff in other countries. And then you're confining yourself to thinking about the most extreme outcome, right? And by doing that, by putting all of your energy there, you don't think about what's happening over here, right? So I think it messes up your gray matter. It messes up your way of thinking about it. And because, like you spoke to, this idea of really stigmatizing, you have to unpack that. Why is it so stigmatizing? Because the presumption that we never say, we have chosen as a nation to have your most fundamental bundle be decided by your capacity to purchase it in the market. Okay, I'm not going to push too much against property rights, but that's what we've decided as a nation. So if you fail at that, we believe there's something wrong with your humanity. And then we reason backward from that. I don't think that's accurate. I don't think that's right. So challenging that presumption that it's primarily some individual or family deficit in capacity is false. The way we have measured lack of access to affordable housing for the lowest end of the distribution for decades, there's always a shortfall. I'm talking units that are affordable to people at the bottom quintile. There's always a shortfall. That's the nature of our housing market. That's what we've decided. So if I take that as a position, I think a little bit differently about folks who are dipping in and out of more precarious housing. It's more normal than you would think. And because we don't ask as many questions about housing precarity and we don't talk about it, as long as you can avoid this thing here, of course, if you're categorized as homeless, you might get access and you might get subsidies. Here's the other thing I will say about the experience of homelessness as a society. When you have an experience of being without home and you have it over time, it imparts unique harm to your body, to your mind, and to your social status in a certain sort of way. So there are real costs to being a society that is comfortable with that. So it's not costless to decide this is how we're going to provide our housing and to decide that we're not going to think a little bit more flexibly and normalize the housing instability that goes far further up the chain. A lot of families, there's a study called the Family Option Study, and it's a study of homeless families, okay? And it's a quasi-randomized study, so it's good data from HUD. And they were looking at different service provision for homeless families, okay? They had 1 million outcomes. I'm just going to focus on one. The families in the Family Option Study are representative largely, they have the same characteristics of homeless families in general, okay? There are service provisions we believe work that are really important. They weren't appreciably different than a subsidy, okay? Families were on the waiting list had to be in a shelter, they had to be in the homeless management information system for 7 days. The idea there is if they could resolve it, they would resolve it. Because being homeless with a kid is really super stressful, right? So in that study, they find that when families who were able to get assigned to the subsidy, they just had all kinds of better outcomes. Duh! Boy, I know where I'm gonna wake up. So thinking about it more broadly and unpacking it and destigmatizing this idea that you're somehow on the wrong side of the economic order because there is this difficulty. The market is not structured to provide sufficient units for those at the low end. That's just how we roll. All right, maybe we change it, maybe we don't, but that should at least help us destigmatize it. Okay.
I love the way you close things.
Okay.
I'm going to stop myself.
I want to just share an example,
please.
kind of off of what you're saying. So, at the VA, we had this after-work activity that one of our veteran groups had chosen to have, and so I gave the welcome. And it was about 9 o'clock at night, and they had a reception. It was ending, and so I thought I was going to kind of walk through and leave, right? Well, this veteran comes up to me, and he was like, "You're the assistant director, right?" And I said, yes. I was like, how are you? And he was like, I'm homeless. It's negative 20 degrees outside. What are you going to do about that? And I was like, okay. So luckily we have some very experienced people who are down the hall. So we went to see our AODs, which is our administrators on duty. And we're walking that way, which is also the way towards the police desk as well. As we're walking, he was very honest and open. He was like, look, I know I'm not the best person. He was like, I'm just in a bad time. He was like, but I have been to those shelters already this week, and I am not going back. He was like, I'm not fit to go there. And I was like, okay. I was like, what options are we gonna have? Like, I don't know, I can't take him home. So we keep walking, and he's like, I'm telling you, if you guys try to send me back to that same place that I was at, it's nasty, it's not good. He was like, I am not used to being homeless. I cannot go back there. And I was just like, okay, we're gonna work through this. And he was like, I will stay in a bed upstairs. I will stay somewhere else. We really can't. We have to work through our rules. So we go there, and we found a place that he was okay going for the night, and he was gonna come back the next day. But truthfully, any of us, like if you found yourself in that situation, would you be willing to go to one of those shelters? And I asked myself that, and I mean, I honestly struggled that night. Like, what if we couldn't have found him somewhere? We would have definitely done something at our facility, but at the same time, what would I do if I was in that situation? I don't know, honestly. Could I go and stay at one of those and be comfortable? I mean, and luckily he didn't have kids with him, but what are those types of places that we're sending? I've been there, I've volunteered, but I can honestly say that a lot of them are not places I want to go. So when you talk about the lower end, how do we fix those too? There's a lot of money, and what is good enough? So I wonder that a lot of times. So that's my question to you guys. What is good enough, and who determines that?
My husband has a saying that it's a hell of a lot easier to get used to the good life than it is to the bad life.
Yeah.
Right?
Yeah.
So, Christina, did you want to add anything to that at all?
I think I added.
Any more? What barriers exist to effectively work across the various systems, touching these families, and how we can improve to better address housing issues impacting health? Christina, we'll start with you.
Sure. I think there are a lot of barriers that we have to address, and I know you hit on some of them earlier about the lack of data collection or sharing across the different groups, and I think that's a really big one. We're truly siloed in what we do, and there's not enough data out there. I really honestly wish, coming from the healthcare side, I wish there was all the electronic health records spoke to each other. Because then, you talk about going into different EVs or seeing different doctors, and again, you're rehashing this conversation over and over again. What brings you in here? Why did you take so long to get this looked at? And a lot of times people beat around the bush. They don't want to come right out and say, hey, I'm homeless, or it's been tough, or I'm going through X, Y, and Z right now, and I'm not sure when my next check is coming through or what I can do. So I think that data sharing is super important. Most of the people who are in the system are really trying to use it for their benefit. There are some that try to work the system, and we see those every now and then. But how can we make sure that that continuum of care is being followed? Or maybe there was a plan that was working, and then this person moved, or they ended up seeing that provider moved, or that social worker moved, and it's not working anymore, but no one can get back to those records to see. I think there's got to be a way to do that, and just try to help with that. The other thing is that when we talk about housing, homelessness, or homeless people, is there a way to get healthcare or health partners into those areas? Because a lot of times it's a high-risk population for more than just they're homeless. It's, like we said before, it's the mental, it's the small health things, the cough that goes undiagnosed for a year, that turns into something worse. The asthma, these are not small, but these are things that can be addressed early on if we could connect the housing and health together. and under one umbrella. And I think if we could do more of that, that would help. Those are some of the two of my big ones. There are a lot of them. I don't know if anyone else wants to go into it.
I would just add, so we talked a lot about the barriers from data collection to the different silos, and I think the funding absolutely starts to need to be a little bit more braided and think about it more systematically. But what I also think about is, unfortunately, not just talking about it, but like doing small things to then make bigger proof points. So if you start kind of where you can get some of these proof points that we all can agree on, and we can all say, well, of course, like that makes sense. It then, I think, helps for broader, more political changes that people might not have thought about before. And so, how do you think about not just settling? Well, you start with doing something where you didn't just settle, right? And I'll tell you, within our organization, I said that I wanted to do this housing program, and they told me no. And I said, well, yes, we'll figure something out. And the other programs were much bigger, and they were like more apartment complex. And so I said, okay, well, what can we do that's small that somebody can't tell me no to? Yeah. And so the smaller, more scattered housing is still getting some proof points. And yeah, it's not solving for everything, but it's starting somewhere, and I think it's a platform we can do more on. And so some is a little bit our own inability to sometimes do something small. We want to always solve for everything 100%. And so just being a little comfortable to start with some of the smaller experiments with the right partners, because it's easier to break down and achieve and put things into action.
And
Go ahead.
yeah, and from a public policy standpoint, there are a lot of barriers that don't allow us to do our jobs effectively. I know it was mentioned a few times up here, but preemption. So if you don't know what preemption is, it's when a higher level of government prohibits a lower level of government from passing policy, basically. And what we really should do is allow local agencies have local control of their housing markets. And one way to do that is to overturn the housing preemption that we see in our state. In the last administration, some of the preemption that was put on state statute includes the licensing or permitting of rental homes or properties, as well as it preempts local governments to implement inclusionary zoning ordinances. So that would mandate or recommend that a certain percentage of all new development is deemed affordable for that local housing market. So that's one piece. The other piece is we're very unique here in Wisconsin that we have this thing called CCAP, and we need to get that figured out because people's eviction records can stay on their record for upwards of 20 years. Even if it goes to court for eviction and it gets dismissed, it stays on their record for 2-3 years. And the impacts that has on getting housing is immense. And that's something that we need to address at a state level. And then a right to counsel. If people have to go to court for eviction, we should be ensuring that they can have representation.
Thank you. Helen, can I just follow up on a question, on a comment? So you talked about starting small and going big. Can you talk a little bit about that process on how you hope to take it to the next level, and if there are any thoughts on that?
Yeah. Part of our, if I just think about our program and talk about that, is, okay, do we stay in Milwaukee County and actually expand it to more individuals, or do we look across the state? And I think part of it, right, because we found the right partner, and there still is more need that we expand it within Milwaukee County. But then we also start to look at other counties across Wisconsin and expand it in that way. But part of it's also working with the right policy. And we actually have had some of our, I'll call it competitors, I should say, my friends that have followed it. And so Children's Health Plan has done an Anthem, and I know at first my team, and they're sitting in the back, we're like, that's terrible, they're copying us. And I'm like, no, that's great. That's great because, it's a proof point that it's catching on and it can work. And so for me, it's like, how do we get that more pervasive across? Everybody gets that this would work. And then we either work with policy or with DHS in the state to figure out how we make it just a program that's embedded in what we do. And so ideally, to me, that's where we would get to someday.
Thanks. Can you talk about the criteria for them to participate into this housing?
Well, the criteria, generally speaking, is high impactable medical costs, whether it be medical or behavioral. And then to continue in the program is probably more important because they have to be continuing with a healthcare plan that we deem that they're, following. We've had a few, where it just hasn't worked either, And so in some cases, working with different landlords to move them and things like that. But it's highly intensive. And so even this morning, if you were there for Drew Altman's, they talked about hot spotting doesn't work. And what I would say is, no, hot spotting doesn't work on its own, individual, So you can't just rely on the data. You also have to look at the people and understand, can you impact them? Are they ready for it? Not everybody is ready to move into a permanent home. Many of ours moved into their apartment, and they were so lonely. They were used to a whole community that supported them, either in the shelter or if they might have been living in Tent City in Milwaukee. So there's all kinds of factors out of just the criteria around the dollars that you have to watch for. And I keep asking my team, what is the magic criteria? Because you have to be really selective in it, I think, for the type of program that we're talking about.
Thanks. Go ahead.
I just read a paper the other day. Maybe you know about this. It was in it's Cleveland, and it was an anchor institution approach, which is the hospital there, whatever the large hospital, became a player, and it diagnosed an entire community. And they went in because they were a hospital. They were a large player in that particular community, and so they thought about a multi-tiered plan with the hospital as an anchor institution, housing across the income distribution, and they had a whole different platform over the course of a whole host of years that was partly about maintaining the housing, partly about building new stuff, leveraging low-income housing tax dollars, but it was all tied into this idea of anchor institution being this large hospital, which also then has a lot of political power and a large employer. So there are different, I'm all for trying all kinds of stuff and then looking what other approaches for doing this. So do you know
I didn't
this
see
in
that.
Cleveland?
That looks
Yeah, I'll send
sounds
you the
really
paper.
interesting.
Quite
Thank you.
interesting. I just read it yesterday.
See how this works?
Collaboration.
Partnership. We're gonna, before we move on to audience questions, I just want to open it up to make sure if there are any other comments you wanted to share, maybe add to comments that you had earlier or anything before I move on to audience questions. All right. I'm getting the notice that it's time for our audience questions. So I think we're going like old school Oprah and taking the mic around. Is that right? So if you want to raise your hand, there'll be a mic coming to you.
Good afternoon. My name is Theola Carter. I'm with the Tammy D. Grisby Office for Equity and Inclusion. I used to be the Bureau Director of Housing for the state of Wisconsin. One thing I would like to say is we're looking at people who may have had some type of mental illness, but we also have people who don't necessarily have mental illness and are in the same homeless type of situation. And one of the issues that I know that's an issue in Wisconsin is that our housing stock is very old. Anything above more than 50 years old, you probably got some lead issues going on there. And if you're going into rural Wisconsin, the housing really isn't there. You also have issues related to what we're calling housing. Affordable housing has a negative connotation when you talk about that. And I just wanted to bring that up as well. I like some of the approaches that you all were talking about as related to it, but you're right. And what you're also forgetting is the history that federal government played in the housing crisis that we're seeing today. Those policies that did not allow people of color to get homes and things of that nature are some of the proliferation of what we're seeing is because of what the federal government has done. And you're correct. There are lots of areas that we need to be talking about. Education, healthcare, transportation, all this sort of stuff intersect. It's more than just one system. I don't have a question. I just had comments. I'm just saying because I know the stuff myself. And some of the things that you're saying are absolutely true, but it is going to have to be a multi-pronged approach with how we deal with the issue that we're dealing with. And it's just not because somebody is mentally ill and let's help that individual. We have single parents. We have families, but with the two-family households where parents are experiencing homelessness and they cannot get places. Yeah. So I'm just saying it's a little bit more than what we're just talking about here in this regard. So I'm gonna leave that to that because that's my 2 cents worth. So,
But can I ask you one question? Given your previous role, what would be, sorry, you wanted to just make the comment. Is there one, what would be the one step you would like to see that you think is kind of maybe a doable step?
One step I would like to see be a doable step. First of all, building homes and stuff like that costs way too much money. I know it costs, it's just a ridiculous price. We provided gap funding at the time because I did the Virtual House Development Program. I also was over the TBRA program, which is the tenants-based rental assistance program. I think it doesn't matter who you are. If you're in a situation where you need some assistance, we need to just break the barriers down and say, oh, that person's not sick, that person's this. Just help the individual and help them move on in that regard. So that's what I would like to see. Because right now, if you're $1 above the poverty level, you're not getting any help, and that's just ridiculous. So I would like to see stuff like that done, and actually HUD needs to be broken down and rebuilt. I'm just saying. So that's my 4 cents worth now.
I will
Thank
say
you.
real quick that when we were talking about stigma, that's a stigma. When people, they don't, just because you're on affordable housing or you need housing, it should not imply that you have a mental issue or that you are disabled or something like that. And that's the truth. So, thank you.
This is more of a comment than a question, and it relates to your comments also. The panel touched on this to some degree, but I would like to enlarge upon this. Is there anybody here from the Housing Ministries of Wisconsin? Okay, well, let me tell you a little bit about this particular approach to housing. As you may know, there's a Section 8 program, as everybody's aware, of community low-cost housing. And there's a tremendously important management process going on in Wisconsin, where in Madison, the Housing Ministries of Wisconsin have 2 units in Madison, Northport and Packer Housing. Are any of you familiar with those communities? And in Milwaukee, they have Cambridge and Plymouth, which are almost completely devoted to elderly, and a very large unit called Green Tree on Totoni Avenue. These units, these units are managed by the Housing Ministries of Wisconsin. Reverend Carmen Porco directs us, and there's a arrangement that he has with HUD where the revenues are tax-free and all of the revenues are committed to the residents. And there is totally nonprofit from his standpoint. Many of these housing developments are run by for-profit operators that pocket the profits. All of the profits from housing ministries go into the benefit of the residents. Madison units are particularly noteworthy. They have enormous education centers. Packer and Northport have very large education centers where all the high school students are tutored after school, and they have very important, extensive programs over the summer. None of these students are dropouts. 80% of them go to college, many of them with scholarships provided by the housing ministries. And it would appear that this is a really great solution if we could convince the federal government to enlarge a program of this sort. And when we have this very segmented society of affluent versus non-affluent, if we could convince some of our very affluent society to help support a program of this type, I think we would solve a lot of the problems that we're talking about today. These units, by the way, these residents have no problems with the other social determinants of healthcare. In terms of utilities, housing, transportation, food banks, pharmacy. The only problem they have is health literacy. And we have a project going to greatly enhance the health literacy of the residents in these projects.
Thank you. Any comments from our panelists at all?
Sounds great. I
We
grew
have
up
a
half a
panel's
block
reaction
from
to this?
Packers and Northport, so I know the area very well. I just said I grew up right by Packers and Northport, so I know the area really well.
Do you agree with the job you're doing?
If those are the facts that you're stating, I mean, that sounds like tremendous results. I love the tie into education. So sounds like something to look into and think about, how we would take that broader.
Thank you. We have a couple of hands up.
I have a question. I was at the Medicaid panel last and Mia Keys spoke, and one of the studies that she mentioned, it almost seems similar in that one of the qualifiers was kind of that high impact cost. But something that she had brought up was that maybe that's not really a great indicator because people don't access the healthcare system for many reasons that might have to do with not being able to afford it and those type of reasons. And so just kind of when you're thinking about expanding the program, are you thinking of expanding to those kind of more vulnerable populations that aren't getting the access they need?
Yeah, definitely, and that was sort of my comments. Let me expand a little bit. Like hot spotting isn't just enough, so just identifying costs already, and that's what I feel that our case managers are so adept at. And so one of the members that we actually put into housing, it was more the impactable costs we knew for the future for her, and that's not easy. I can't wait to actually hear her later this afternoon. She's here. I'm putting a shameless plug in, I guess, around AI. And how do you think about, impactable future costs so you can predict that as well. But I don't think hot spotting and just the level of costs, but what the level of cost does do for us, if you can kind of understand, is also helps us pay for it, right? So, we aren't, these members, it's not like we get some sort of reimbursement for that. We're looking to fund it through those costs. And so impactable future, you're really not, getting a funding mechanism, but we absolutely look at it because of course that helps our overall results and the outcomes for those people. But absolutely. So I don't know, we need a different word than hot spotting. It's like smart hot spotting or something like that. Either one. So I'm looking for impactable costs or future cost savings from it. But you are so right on, and it's why so many of those studies they're looking at right now are saying, well, you didn't impact anybody. Well, it's because it's really hard to predict future costs. And so those kind of studies are really, you have to kind of take them with a grain of salt.
Awesome. I have 2 questions, actually. So we talked a lot about affordability and quality of housing, but I was wondering if there were any suggestions or best practices around sustainability that people are, or stability, that they're staying in their housing, because we know that has such a huge impact on their education. And also, what do you see as best practice local solutions for communities to take?
So, can I say?
Yes,
So,
please.
anything that rationalizes your renter market and makes the rules of the game at the low end, standardized leases for a standardized length of time, something about the consistency of the quality, then makes the entire low end of the market rational and predictable. So I would argue for those types of mechanisms to rationalize the low end of the market, like other cities have done. That's not an uncommon thing to choose to do. Yeah.
I was just going to comment, and I didn't even talk about this in the kind of general panel, but the one thing that UnitedHealthcare has done is actually invested in more affordable housing, right? So increasing more units, and we invested $6 million on the east side of Madison. It was Harmony Commons, and then another unit within Milwaukee in the 3rd Ward. And what I didn't talk about is I really wanted to focus on our program. But when you talk about like that, and when Marah talks about like, so how to systematically we move the system more, like how do we encourage more larger corporations or health systems to also take their dollars and put it back into the community, because it does better overall good. And so thinking about that concept more, and again, these are tax credits. So how do you make sure that organizations know these are things they could be doing for increasing the number of units, but then goes to stabilization. So we just have to think about more and more how organizations understand they could actually be doing something with their dollars. And at the end of the day, it's actually good for the corporation and it's good for the community at the same time.
I was going to say also, I think as many transition in places we can get where you you start and then you stay there for your permanent housing. I think that's important. But what's also important is trying to also focus on that community too, because already you're getting a certain subset of our community. And so how do we build programs in those areas to really push people to want to excel, for their children to want to grow and to have experiences that children in maybe other zip codes don't necessarily get. So I think those programs, and again, we would need to utilize other support systems to have more housing like that, because once you move someone in and that's their permanent housing, it's over, right? For that area, like you get the housing and now you need another location to move other people in. So that's what I would go with.
Thank you. We have time for one more question, I think. Where's my Oprah? Oh, there she is. Makes it a little tough around here.
There were a few. Okay, all right. I don't know, is there anyone else who has a mic? I'm honored to be able to ask the last question, but I was just wondering, how do you approach kind of touching on some of the issues that were discussed earlier, racial and income segregation in your work, and some of those larger market forces like out-migration in rural areas and gentrification in urban areas that impact housing quality, affordability, availability in our communities? And are you aware of any promising policies and solutions that can help communities deal with that?
Wow.
Did you want to repeat that?
Quite the question.
Did you want to repeat that one more time? At least the beginning.
Sorry, so the question was around some larger forces and effects of former policies like racial and income segregation and out-migration and gentrification in different areas, and how that impacts housing. and the housing stock and housing availability? And are you aware of any kind of more localized, but perhaps like larger level solutions and policies to some of these larger forces?
Marah,
Say something.
Yeah.
So did you read the book, The Color of Law? Yeah. And so the argument in that book is the federal government is directly involved in the processes of redlining and racially restrictive covenants and the like. And part of how I read that book is that the local players and the local actors and the way that these kinds of racialized, in that time period, anti-black policies that are directly related to a lack of capacity to get property and gain wealth, that the specificity of that story at the local level really matters. So that part, I think you can't do any of this without the historical context. And one thing, because I've lived other parts, the unique story around that in a region, I think, matters, why the stock is racially and income segregated. So let's look at it the other way. There are other communities. There are communities, these are expensive communities, that are racially diverse because they were created that way purposefully. And there are a few communities that are income and race diverse, but it took a group of like actors to decide they wanted to do it, to construct it, because the default is income and race segregation. That is the background in which we all swim. So to swim against it, you'd have to say, this is the history, we want to do something different. Now, the other resource there is a mixed income housing initiative, Cleveland. They have a whole shop over there. They're kind of thinking about it, a little bit at the lower end. But I think that's a useful way to think about it. I think you have to acknowledge the history and decide you want to do something different. Mm-hmm. And so you can't just talk about the rental market, you have to talk about ownership for folks too. Mm-hmm. So I don't know enough about this state to know why every time I do something, someone gives me an earful about this is how this happened. Because there are lots of players historically that created what we have. So you have to look at it, know who they are, know what was decided. People can work through their feelings about that, and then decide what you want to do. There isn't any way. That's America. This is what we're going to have to do if we're going to move forward, or we don't. So thank you for that question. Yeah.
I think we need to end exclusionary zoning, which is our status quo, and that basically would mandate that you can't have zoning laws that prohibit the development of multi-unit housing or affordable housing. That's real life racism, right? Exactly. Like, that's our status quo. We need to overturn that. Otherwise, we're just going to continue to perpetuate these inequities that we're seeing. Point blank.
Can I just ask you a question? You brought up a lot of good ideas. How do you have any suggestions or thoughts on how we take this today, and how do we get there? How do we encourage those changes in that policy?
I have some Milwaukee thoughts. Where are the Milwaukee people here? Who are the Milwaukee developers?
Yeah.
Okay, they're my colleagues. I don't understand why we can't leverage WIDA dollars and the low-income housing tax credit for the gentrifying places in Milwaukee, so that people who are land trusts or whatever who want to benefit from this run up in costs, if there are people there who actually want to be part of an ownership type of a strategy. So I think it depends. I don't know enough about Madison to know what's going on, but the people in that particular place, whatever they're trying to do, I think there are going to be these type of solutions. I think. Right, because if you have things gentrifying and everything is going up, you could benefit from that appreciation. If you want to stay there, if that's your, many people are very attached to place.
I'd agree with that. I really would.
Just start having the conversations. I think going into those spaces and talking to people and collaborating, exactly what we're doing here, is so important, and breaking down those silos.
I think you're going to have to change policies too. I mean, that is, I'm sorry, I'm taking over for you.
Yes.
But policies have to change, because when people don't want to do something, the policy says, change the policies. Get the folk out of office. Oh, that's not doing what you need to do. And on the other hand, we've already tried just putting people in specific places. We already got the Comptons and the other places that have proven that putting all people with the same income level in a specific place don't work. We already know that because of the racism and stuff that existed within there. And on the other side too, we always talk about the landlords and what they are doing. We have to also talk to the people who are living in those places as well. Because if I'm a good landlord and I'm taking care of your stuff and you're not paying me rent, I can't fix your refrigerator. So it has to be on both sides that you have to look at it when you start dealing with issues as it relates to housing deprivation or disparities and everything. So it's gonna have to be government, education, transportation, and all those other systems, along with that person having an invested interest in their community.
Thank you. And with that, we will close it out.
Have a great day.